Hi, I'm Carolyn Crooms. I'm a neuropalliative care physician here at Mount Sinai, and I'm going to be talking about palliative care for amyotrophic lateral sclerosis, or ALS. Just to give a little bit of context about myself, I'm a neurologist and a palliative medicine physician, and I work doing palliative care embedded in the Mount Sinai ALS clinic. So this is an area of palliative care that's near and dear to my heart, and I'll talk a little bit about my experience with it. So I have no disclosures. And my objectives for the talk are to firstly review the pathophysiology of ALS, secondly, to identify common symptoms in ALS, and then to go over treatment of the ones that are less commonly managed in general palliative care practice. Many of the symptoms are sort of common in palliative care and others are not so much, so I'll focus on those ones. Thirdly, I'll discuss some considerations in decision-making for both PEG placement and tracheostomy as kind of major decision points in the ALS trajectory. And finally, I'll propose an approach to integrating palliative care into ALS management based on my experience. So ALS is a neurodegenerative disorder that's multifactorial. So it's due to glutamate excitotoxicity, oxidative stress, and neuroinflammation affecting both upper and lower motor neurons. So upper motor neurons are the ones that run from the brain and through the spinal cord. And then the lower motor neurons exit the spinal cord and connect to the muscle or send signals to the muscle. Both types of motor neurons are affected in this disease, but the symptoms that relate from that are caused by the two different types of injury are different. So upper motor neuron signs, and again, that's the cortex to the spinal cord, include spastic paralysis. And by spasticity, we mean essentially like tight muscles. So if you try to move the joint, move a limb across a joint, the muscle kind of catches or sticks. It's hard to move. And then also brisk reflexes. So that would be more of a clinical sign on exam rather than something reported by a patient. Lower motor neuron signs in contrast, and again, we're talking about the spinal cord communicating with the muscle, would be more like atrophy or wasting. People will lose muscle bulk, particularly you'll see it in their hands, but can happen anywhere. A flaccid paralysis, so in contrast to that tight joint that's hard to range in the upper motor neurons, we're talking about a very loose, floppy limb. Depressed reflexes, again, a physical exam finding, and fasciculations, which are twitches of kind of individual muscle fibers. So you can see like in somebody's tongue who has ALS, they may have kind of twitching, and it can happen in any muscle of the body. In terms of epidemiology and diagnostic workup, this is a rare disease. So in the US and Europe, incidence ranges between 1.5 to about 5 per 100,000 per year. And the vast majority of those cases are sporadic. So older age is a risk factor, family history and cigarette smoking are risk factors. There are some other possible environmental conditions. So if you work in a VA, you may know that ALS can be a service-connected disorder for people who were, for example, in Vietnam during certain times. And then 5 to 10% of cases are genetic and may be familial. And the most commonly associated genes are listed here. Make note of SOD1 because there is actually a targeted treatment for that. And I think people are often, we think of ALS as, because it's a motor neuron disease, it's really about weakness. And while that's true, and we often talk about people being aware as their function declines, which is also true, cognitive decline is actually also can be a big part of it. So about 50% of patients experience cognitive decline, and about 20% of people with ALS are also diagnosed with frontotemporal dementia. So these are people who have decreased executive function. They may behave very inappropriately and have kind of bizarre behavior. Unfortunately, diagnosis of ALS is very often delayed. And a big part of that is diagnostic hesitancy. I think ALS looms large for a lot of clinicians as one of the most devastating illnesses, certainly within neurology, and people are really reluctant to diagnose ALS when there are, in fact, a number of ALS mimics. So things like cervical spinal cord stenosis can present with progressive weakness, atrophy, spasticity. And so if people present in that way, they may be misdiagnosed, and sometimes, perhaps even often, they'll have surgeries for conditions that are not actually responsible for their symptoms. And a part of that is that sometimes often the symptoms appear in one limb first. Kind of one of the hallmark findings in ALS is to have upper motor neuron and lower motor neuron signs in a single limb, and then will spread to other limbs. So it's important to do a diagnostic workup in order to rule out the mimics, but it's also important to keep this diagnosis in mind when people present with progressive weakness. So there's quite a number of laboratory studies that are typically sent. An MRI of the brain and spinal cord is usually done. And then electromyography with nerve conduction studies, also known as EMG, NCS, would be the typical test that's really needed to diagnose ALS. There's no single diagnostic test, but EMG, NCS is probably the best one, and that's done typically by a neurologist. Unfortunately, there are very few disease-modifying therapies in ALS, and none of them have a huge survival benefit or functional benefit, but we have people take them nonetheless. So riluzole is probably the most common one and the oldest. It inhibits glutamatergic excitotoxicity. It's a pill that's taken twice daily, and on average, it extends survival by 2 to 3 months in clinical trials. 1 year survival probability is increased by 9%, and then survival without tracheostomy is also significantly increased. So these are things that people really care about. And when you're talking about a prognosis on the order of 3 to 5 years, 2 to 3 months is non-trivial. Edaravone or radicava is a free radical scavenger that until very recently, just in the past year or two, was exclusively parenteral. So people would have almost a chemotherapy-like regimen, but now there's an oral formulation. This one may or may not have a survival advantage, again, on the order of months, but really the benefit that people talk about is potentially slowing progression and specifically functional decline. And then finally, a new one that's only for a small handful of patients, tofersen, which is an antisense oligonucleotide to SOD1, which you may recall is the gene that I highlighted as implicated in certain genetic cases of ALS. And that's only for patients with the SOD1 mutation. It's an intrathecal drug that's dosed monthly, and it reduces concentrations of SOD1 in CSF and neurofilament light chains, excuse the typo, in plasma. But there's actually no apparent clinical benefit as of yet. So I think studies are ongoing, but it does have FDA approval as of 2023. In terms of staging and clinical trajectory, there are a number of different ways to stage ALS, but just to give you a sense of the overall clinical trajectory, at the top we have King's staging. So you can see the boxes talk about clinically what's going on with the patient, and then the arrows show the average time to each milestone. So in stage 1, you have a first region. So, a lower extremity, for example, average time would be about 13 months. And then in stage 2, going to another region, so on and so forth. And then jumping ahead to stage 4, we're talking about a need for gastrostomy, which I'll talk about later, and a need for non-invasive ventilation. And then if you look just under the arrows, it also shows the median survival at each stage. So not terribly long. And then just at the bottom, the ALS mitose staging is more based on the domains and has a probability of death underneath each one. So I think the King's is maybe a little bit easier to understand. But these are the types of ways that people think about the ALS clinical trajectories, really in terms of functional decline and then need for, in particular, artificial nutrition and non-invasive ventilation, both of which I'll talk about. So multidisciplinary ALS clinics are associated with enhanced survival compared to being followed in a general neurology clinic. So like palliative care, ALS management is really a team sport. And I'll just go through what each of the people in an ALS clinic typically does. Not all multidisciplinary ALS clinics have all of these individuals, but they certainly all can have a role. And I would also just note that in the center, we have the person with ALS, and I think really the caregivers of the person with ALS should also be in there with them. The ALS neurologist obviously is managing diagnosis, treatment, and to a large extent, symptom management. The ALS Association, or in New York, we have ALS United, which is now a separate organization. They will often send a liaison to multidisciplinary clinics if they're affiliated with a chapter or accredited by them. And they play a really important role. So it's a patient advocacy group, essentially, and they have support groups. A lot of patients and caregivers will connect with each other this way. They have really important conversations and share resources. There is a loan closet, which is incredibly important. So ALS is very disabling, as we'll talk about, and as you probably know, and there's a lot of durable medical equipment, or DME, that's needed, and it can take a long time to get them. For example, if you need a power wheelchair, which most people do at some point, it can take many months to get, and you really want to get the best one that they can get, because Medicare will only cover one wheelchair every 5 years. So you don't want to have people just get whatever wheelchair they can use in the short term while they wait for their fancy power wheelchair. And the ALS Association, or ALS United, can usually provide as a loan a wheelchair that belonged to someone else in the past, and they can use that power wheelchair while they're waiting for their own custom fitted wheelchair. And they do also have some financial resources, so they can give people at times small grants to help with things like hiring outside caregivers, which is a huge expense for these patients. Social workers, certainly do all the wonderful work that social workers do in all cases. A big one here is navigating home care needs, because again, it's very difficult to manage without outside help, and people who don't have Medicaid don't qualify for that. And if they do have Medicaid, it can be difficult to get the hours that they need. Speech pathologists help with the speech deficits and also with swallowing. So unfortunately, a lot of speech therapies that might be used in other populations don't really work for ALS. So it's actually most important to identify augmented communication resources. People do things like text-to-speech apps. They may have an eye gaze device, and what is appropriate for one person may not be appropriate for another. So the speech pathologist can help with that. Swallowing advice, and sometimes dietary consistency modification advice. Similarly, the registered dietitian will help with dietary modification, so weight loss from muscle atrophy, from dysphagia, and from poor appetite, from how long it takes to eat a meal, if you have weakness in your arms, all very significant. And so the registered dietitian can help with modifying the diet to make it easier to get more calories more quickly and more safely. And then also they may provide advice for artificial nutrition for patients who have a gastrostomy. PT and OT obviously help with both navigating ADLs and with recommending DME. A respiratory therapist, or in some clinics, there may be a pulmonologist, will monitor pulmonary function, and then also guide DME provision for respiratory support. And I'll talk about both a non-invasive ventilator, cough assist, later on in the talk. And then finally, mental health professionals. As you can imagine, this is an incredibly difficult disease for patients and caregivers. And so if there is access to a mental health professional, that can be very helpful. Sometimes palliative care plays that role to an extent, I can share. And then nursing professionals or other care coordinators may be involved as well. So there are many symptoms in ALS, unfortunately, some of which may be very familiar and are things that you would manage all the time, and others may be a little less common. So as you can see, I have this original diagram that shows, and this is from ALS Pathways, that shows some of the common symptoms, and then I've added in cognitive symptoms and others because those are also really important and really distressing for patients. So we talked about the cognitive symptoms a little bit before, and the fact that it can be comorbid with frontotemporal dementia for 20% of patients, and another 50, or a total of 50%, so another 30% may have just cognitive dysfunction in general. But pseudobulbar affect is something that may not be as familiar to a lot of people. I'm actually going to talk about that in the next slide, so I won't go into it too much here. Executive dysfunction, as I mentioned, that goes along with FTD, and then sometimes behavioral changes, again, for the same reason. Bulbar symptoms, or what they're calling here head and neck symptoms. This is when your cranial nerves are weak, the motor nerves, can affect your swallowing, your speech, and because of the difficulty swallowing, people have excess saliva as well. So it's not so much that they're producing additional saliva, it's that they have a weaker swallow, maybe are not swallowing as often, and so they don't clear the secretions very well. Respiratory symptoms are really huge. As I'm sure most people know, neuromuscular respiratory failure is generally the cause of death for people with ALS, and there can be a lot of symptoms along the way. Obviously, shortness of breath is a big one. Restricted breathing, meaning people really can't take a big breath. I think it is really important to note, and I will talk about this more later when I'm talking about non-invasive ventilation, that it is not a problem with oxygen exchange. So people's lungs with ALS function perfectly fine. The problem is that there's weakness of not only the diaphragm, but the intercostal muscles, just all the accessory muscles used to take a big breath. And so that is really the fundamental problem, and people can certainly feel short of breath. They can have difficulty sleeping because of orthopnea and just shortness of breath in general. So it's very common that people who have early respiratory failure will initially complain of insomnia and maybe morning headache, sort of similar to what somebody with obstructive sleep apnea might complain of. And then I think upper body and lower body symptoms, one way to think of it, but really there we're talking about weakness. So people can have weakness, obviously, in any of their limbs, reduced range of motion, all that can affect their ADLs, they can have frequent falls. And then I think noting also the spasticity can be very uncomfortable, and cramps are not on here, but that's also a big one that I will talk about. And then just in terms of the others, again, all of these things can be really sort of multifactorial and contribute to each other. For example, constipation is not necessarily because the gut is in any way affected, but people may be dehydrated because they have difficulty swallowing, or they just have difficulty getting a glass to their mouth often enough. They may be immobile. They may be on different medications. So all these things can contribute to constipation, and that can be overlooked because they are, we're so focused on all the other symptoms they have. Depression and anxiety, as you might imagine, very common. Fatigue is a really, really big one that can be very tough. Again, can be multifactorial because of poor nutrition, because of respiratory failure that's untreated, and then also just from the disease itself. And as I mentioned, headaches, again, usually from the respiratory failure. So now I'm going to move on to talking about some of those less common symptoms that might not be managed so often by people specializing in palliative care. So pseudobulbar affect can be very difficult for patients and caregivers. This is a symptom of involuntary and uncontrollable swings in affect. Most often, we're talking about spells of laughing or crying that are either out of proportion to the situation, atypical for the person, and they can also be unprompted. So you could be just having a normal conversation and they have a fit of laughter, or you'll think about somebody who maybe has always been pretty stoic, and then now they're crying at a sort of sad commercial, or just in the middle of a conversation about something that is not to you all that sad. And it's thought to be caused by corticobulbar tract degeneration or cerebellar modulation of emotion. Again, think of cerebellum as modulating motor control, but in fact, it also modulates emotion. There are a few treatment options. So Nuedexta is really the one that has been shown to work in a clinical trial, but sometimes people will use tricyclic antidepressants or SSRIs. Sialorrhea and thick secretions are really big, really uncomfortable. So the sialorrhea, as I mentioned, is from bulbar weakness leading to difficulty clearing secretions, so people can have drooling. Medications, I would say most often we use glycopyrrolate or a tricyclic antidepressant like amitriptyline or nortriptyline. Atropine and scopolamine can be used, but I have them in parentheses because they're not necessarily as well tolerated, and we don't want people to have the anticholinergic effects. Procedures that people will do, so Botox can be really helpful. It's pretty well tolerated, actually. You inject Botox into the salivary glands and it reduces saliva production. But like I said, pretty well tolerated. You only have to do it every few months, which is nice, especially for people who have a hard time leaving the house and they're already on a lot of medications. I haven't had anybody do radiation to the salivary glands, but it's also an option. And then for DME, people might need home suction. And then unfortunately, people can also have thick secretions for a variety of reasons. Sometimes it's from dehydration, which we talked about being common. It can be from a weak cough. So if you can't take a big breath, it's breathing out really that helps secretions move up in the airways. And if you have weakness of your respiratory muscles, you're not doing that as effectively. So people can get these kind of thick secretions that sit. They'll talk about having a hard time coughing them up, and then they can't clear them once they get them, higher up. So hydration is important. That includes both oral hydration or for somebody who needs a feeding tube, and then also humidified air from a non-invasive ventilator, which again, getting to that, but just know that if people have a non-invasive ventilator, the air can be humidified, and that can kind of relieve not only thick secretions, but also dry mouth. Mucolytics like guaifenesin and acetylcysteine can be used. We'll commonly have people just get over-the-counter cough syrup if they're complaining of thick secretions. And then finally, what people might not be as familiar with is a mechanical insufflation-exsufflation device, also known as a cough assist. You can see it initialized as MI-E, and that's shown in the picture to the bottom right. It's a device that gives a little bit of positive pressure and then very quickly transitions to negative pressure. So insufflation pushing air in, and then exsufflation pulling air out, which essentially mimics a cough like one would do naturally, and can just help to bring the secretions up, and then someone can either spit them out or they can be removed via suction. So that's a really important one. Can also help people with lung volume recruitment. So often this is recommended fairly early on, and peak cough flow is one of the respiratory pulmonary function tests that is often tested in an ALS patient. Spasticity and cramps also very common. So I talked about the spasticity before. Again, that is an upper motor neuron sign, and people have difficulty kind of ranging across the joint. And they might complain of like spasticity. Maybe they'll say they can't bend their leg, something like that. Another thing that maybe non-neurologists would be less familiar with is spastic speech. So you can get upper motor neuron dysfunction that's bulbar as well. And the speech can be very halting, very forced, just sort of difficult to get out. And that sounds a little bit choppy when you hear it. So that's just another thing to keep in mind. Usually treated with muscle relaxants, just like people are probably familiar with. So baclofen, tizanidine. Sometimes people need Botox to select muscle groups. It's not something you can do if somebody has really diffuse spasticity, but if they have like very painful spasticity in like a few muscle groups, then Botox can be helpful. And then a lot of DME, so braces and splints can alleviate the pain of contractures. For example, multipodous boots can help when people have a lot of pain in their Achilles tendon because they have weakness of foot dorsiflexion and they kind of develop these contractures that can be really painful, but splinting them up can help. Cramps are more of a lower motor neuron phenomenon. So here, rather than complaining of that spasticity and the tightness or rigidity, people have more pain in the muscle itself. You can actually also treat those with baclofen. Mexiletine is another one if they don't have cardiac disease. I haven't really seen carbamazepine and phenytoin used, but they can be. And then stretching and exercises can be helpful as well. Although I think those ones there's a little bit less evidence for. So management of dysphagia, I think this is a really important one. So we talked about the clinical trajectory that people experience. And in the next couple of slides, I'll be talking about those later stage, for most people, issues of artificial nutrition and respiratory support. Sometimes people will present with bulbar symptoms from the get-go or very early on. There can be a rapid course, can be slow progression. And I think it's important to keep in mind that everybody is different. And although ALS is a more or less universally fatal diagnosis and usually has a prognosis on the order of short years, some of the treatments that we're discussing are life-prolonging. They improve quality of life, and they're not necessarily the same as what people would envision from diseases that we're more familiar with. So it's just important to not presume that a treatment is, for example, non-beneficial just because somebody has a short prognosis. So with that caveat said, dysphagia is something that more often develops a little bit later on in the disease course. People will talk about having difficulty swallowing, maybe choking or coughing on certain things. They might not, they might just talk about having slurred speech. And so it's important to kind of ask some questions about it. And there are a few things that we do along the way to support people before they need to have a PEG placed or be considering it. So over here on the right, this is kind of an old practice parameter from the American Academy of Neurology, but it's still sort of stands, I think. So before somebody has some of the indications for PEG placement, which I'll talk about, there are different types of dietary modification that you can do. So it's not that as soon as you have any type of dysphagia, you go straight to doing a modified barium swallow and having a PEG placed. There are a few different things that we might do to help support somebody nutritionally and to prevent the risk of aspiration pneumonia. So sometimes people will start by dietary modification. They'll chop their food up small, then they might put a lot of gravy on it. That makes it easier to swallow safely. And they might then, move on to pureeing it, for example. People tend to need a lot more supplements. We'll kind of say, take an Ensure and blend it up with ice cream, because really the weight loss is a major issue, not only for just general well-being and energy, but also for respiratory support and symptoms. You need to have enough strength, and you're trying not to lose more muscle than you would be anyway. Eventually, there are a couple of indications for placement of a PEG. One is the inability to meet nutritional needs. So having a substantial weight loss. And I don't think there's like a particular number that people look at, but often if we're talking about, 5 and 10 and 15 pounds lost between visits every 3 months, that's certainly very worrisome. Dehydration is another big one I keep harping on. And then, of course, symptomatic dysphagia, especially if somebody has had, for example, an aspiration pneumonia. And, I talked about not conflating the ALS experience or context with other diseases. I think a lot of the time in palliative care, when we're consulted to discuss PEG and support decision-making around that, we're talking about things like Alzheimer's or other neurodegenerative cognitive disorders, where we don't necessarily think that placing a PEG is going to reduce the risk of aspiration. But that's not the case with ALS necessarily. There may be a point where it would be true, like if they have really reduced FVC, for example, but it actually, there is evidence that it prolongs survival, and it may also improve some symptoms and function. You could imagine that if you're really dehydrated or you're really nutritionally unwell, that you would have worse fatigue, can actually affect, as I mentioned, the strength of your voice, and your breathing and things like that. Similarly, for management of respiratory symptoms, there's a lot that we can do on the way to tracheostomy, which is one of the things that probably palliative care folks are consulted about more often, or might be thinking about when we hear about ALS and respiratory failure. And again, there's this kind of flow diagram on the right that shows the approach that one might take. So we already talked about the cough assist, or mechanical insufflation exsufflation, which increases peak cough expiratory flow, helps to clear secretions, and improves work of breathing. People are often using cough assist, a couple of times a day, maybe more as the disease progresses, or if they have like a cold or something. And then one of the other really key pieces that's so important in ALS is non-invasive positive pressure ventilation, NIPPV, or also NIV, just non-invasive ventilation. This is not necessarily BiPAP, which is often talked about. People will sometimes have like a more kind of sophisticated version of bi-level positive pressure ventilation that is a little bit more responsive to the patient's needs and breathing. But for all intents and purposes, we're talking about something like BiPAP. And this really is a life-prolonging treatment. So it increases survival by 11 months compared to controls. It can slow decline in forced vital capacity, which is one of the key PFTs that's tested in ALS. And it also improves quality of life through a number of mechanisms. So it improves energy, vitality, shortness of breath, daytime sleepiness, in part because people are sleeping better at night. The dyspnea and orthopnea are typically worse at night because when you're lying down, and asleep, you don't have as much, you don't have gravity helping you, and you don't have as much, voluntary input into your breathing. Depression, concentration problems, I mentioned sleep quality, and physical fatigue, all of those things can be helped. And one that's not on here that I would mention is just people can experience hypophonia, and that also can be in part from their respiratory failure. So we might think of it as a bulbar symptom like their dysarthria, but in fact it's a respiratory symptom. And I just also want to note that except for palliative purposes at the end of life, patients should not really be given supplemental oxygen by nasal cannula, the way we might for other people with shortness of breath and respiratory failure, due to a potential for decreased respiratory drive, right? So this is a neuromuscular respiratory failure. People get hypercapnic, not hypoxic. It's a ventilation problem, not an oxygenation problem. And so you really want that non-invasive positive pressure or just any type of positive pressure ventilation, not supplemental oxygen. So that's really important. And I think another thing that's important to mention is that people don't necessarily go straight from their first time being intubated to a tracheostomy. So again, I think a common scenario where palliative care clinicians are going to encounter ALS patients is in the hospital, maybe intubated, they have a pneumonia, they're intubated, maybe they were or were not on NIV at home. And the conversation is about tracheostomy with the ICU team. But there might be an opportunity for them to be extubated to NIV. These are not the same as people who can't get off BiPAP, and so it's a conversation about trach. People with ALS can live with NIV for many months, for years really, and not necessarily have to have a tracheostomy. There are even some pulmonologists who say you should really never have a tracheostomy. I don't know about that, but it's one of the things people say. So I think it's important, in my opinion, that if someone is intubated, or even, looks like they may be intubated with ALS in the hospital, talking to their outpatient neurologist, their ALS neurologist, if at all possible, about what is possible for them is a really important piece of setting the stage for palliative care team and the inpatient teams before having a conversation with the patient and the caregiver, because we don't want to be pushing people to make a decision about trach prematurely. And certainly, I think if somebody is intubated, it's an appropriate time to bring up the conversation. Unfortunately, a lot of people are really not aware that a decision about trach is going to be on the table later. So that's a hugely important thing that palliative care, I think, can bring to the table with anticipatory guidance and having those difficult conversations. But I think in terms of making a medical recommendation around it or sharing medical information about that particular moment in time, it's important to really be confident, or at least have a good sense of whether invasive ventilation with a tracheostomy is truly necessary. And again, this is all sort of shown in the diagram on the right. So let's say that someone has had progressive disease. Maybe they have a PEG, and maybe they've been on non-invasive ventilation for a long time, and because of their bulbar weakness and their respiratory weakness, they take such small breaths and they can't protect their airway because of the weakness of the muscles here. And they've decided that they don't want to have a tracheostomy, which the majority of people in the United States choose not to have one. That would be a time to be talking about hospice care. So for patients who elect not to have a tracheostomy, these are the recommendations from CMS. So the first piece is their respiratory status. So if they have forced vital capacity less than 40% of predicted, either seated or supine, and 2 or more of the listed respiratory symptoms, so things like dyspnea at rest, orthopnea, weakened cough, etc. Or if they cannot test their FVC, which might be because, for example, they have bifacial weakness and they can't form a seal with their lips around the tube you have to blow into, then you can actually use 3 of those symptoms that are listed under number 1 above. That would also suffice to contribute to hospice eligibility. And then severe nutritional deficiency, which could be dysphagia with progressive weight loss of at least 5% of body weight with or without election for gastrostomy tube insertion. So a very important thing to know about hospice for ALS is that you can still have your non-invasive ventilator and your PEG tube and be on hospice, because those things under these circumstances do not prolong life beyond 6 months on average. We do expect people to continue to decline. So you can still have those things. Sometimes you have to push back a little bit with some hospice agencies if they're not familiar with ALS patients. Communicating that would be important, or communicating around it. The other thing is that because there's so much DME that's really important in ALS, especially the non-invasive ventilator, not only for life prolongation, but also for quality of life, it's really important to make sure that they get those things before they go on hospice, because even though you can continue your NIV, hospice is not going to get you a new one. So sometimes we'll have people who are making a decision maybe a little bit more upstream, but they have a lot of symptoms, and we might say, well, let's hold on until you can get the NIV, which is a pretty quick process, and then we can move forward with hospice enrollment. Same thing with a wheelchair. That's also an important one because it takes a long time if the person would really benefit from one. So just wrapping up in the last few minutes, this is one approach to palliative care across the disease trajectory in ALS. This is kind of how I think of it in my practice. Again, I'm in our ALS clinic, not in every visit. I'm there about half of the clinics that we have, and so I don't necessarily see every patient at every one of their visits, but hopefully I'm meeting everybody at least periodically, and they usually do have visits every 3 months with the whole ALS team to evaluate for progression, to manage any symptoms, to get updated PFTs and a swallow evaluation, and so forth, and to see me. So I've kind of divided it into, and again, this is not using the established staging. This is sort of just more of a subjective way to think of it. But so diagnosis, kind of early stages where people are getting used to things and maybe they have like some weakness, but not bulbar symptoms. Then when there's onset of bulbar symptoms, onset of respiratory symptoms, which can happen at the same time, not necessarily in this order. And then finally the real end stages like we talked about. So early on, my main aim or objective is to explore patient and caregiver coping. It's a real shock for most people. As I talked about in the beginning, there might have been a really long delay in getting the diagnosis, and people can really be in shock. So just thinking about how they're approaching things, building rapport, particularly talking about the ALS clinic as a source of support, or if you're in an outpatient palliative practice, palliative care practice can be a source of support, and designating a healthcare proxy, which is a big one. And then in the early stages, really more exploring coping. I might start talking about goals and values, but not tying it to any medical decisions. Maybe it's exploring what their information preferences are. Are they someone who wants to plan ahead? Or are they somebody who's like, let's talk about it, cross that bridge when we come to it? And then just sort of getting a sense of what's important to them, what brings them joy, what contributes to quality of life. So just so that we as a team know what's going on with them. When they start to have bulbar symptoms, we might be still exploring coping all the way, exploring home care needs. We might have already been doing that, but I think it's a good way to, again, like build rapport and have people feel like we're doing more than just talking about end of life stuff when maybe they're getting their symptoms managed by somebody else. And then I'm also introducing a PEG at that point. I would also just note that when we're talking about PEG with ALS patients, a lot of the time we're actually involved. I'm actually providing more information and reassurance about it, just the logistics, because people have a lot of misconceptions about how a feeding tube will affect them, and a lot of people say I would never, And then actually when you explain it to them, they say, oh yeah, actually I would do that. And then with the onset of respiratory symptoms, you might imagine we're introducing various respiratory supports with all of these, kind of checking in about what they know, what they've been told, and then providing information about all of these. I already talked about the fact that intubation in a person with ALS does not inevitably mean tracheostomy. And then of course, in the end stages, if I haven't already, talking about a MOLST if it's appropriate, and talking about hospice if it's appropriate. And hopefully all of those things build to make that a more successful conversation. So just some take-home points for this really serious illness. ALS is a neurodegenerative disease of the motor neurons, but it can affect cognition and other organ systems, causing uncomfortable symptoms and poor quality of life for patients and also for their caregivers. Disease-modifying treatment options are limited, but there are many, many supportive therapies that are best delivered, like palliative care, by an interdisciplinary team. And I think it's really important to keep in mind that although the prognosis is poor, life-sustaining treatments, such as non-invasive or in some cases invasive ventilation and artificial nutrition, can still be beneficial. So we don't want to be jumping ahead to the end of someone's life just because time is short. And I know I'm preaching to the choir here for a palliative care audience, but I think it's worth noting. And then finally, I think be aware of the disability paradox, both for patients and for clinicians, and just clinician bias in general in this regard, that, somebody who says at the beginning, I would never want to live if I had to have a feeding tube, they may still say that later down the road, but they may not. And so having those ongoing conversations is really important. And we may be wrong about what people are willing to tolerate, as you all know. All right, thank you very much. That's the end of my talk.